viewer it will come here.
It's not
رسالة من
functioning.
أسامة يا محمد شفتها؟ only use Zoom advanced screen share to only share
لكن
slide.
نحن this is not our problem يا طه. نحن our problem انه لما يظهر لنا نحن البريزنتر السلايد شير حقها ما بيظهر لها هي من غير بريزنتر فيو. هي عاوزه البريزنتر فيو تظهر لها هناك في قطر. عرفت كيف؟ هي دايره الفيو دي تظهر لها هي هناك لدكتوره سهير. You got my point. It is not about وضع الزوم كيف بالنسبه للاودينس. نحن we can control الفاينل appearance لكن we cannot control البريزنتر فيو.
لا أنا فاهم كده محمد يعني. أوكي.
هو بيتكلم عن انه السكرين تجيهم هناك من غير صوركم انتم. يعني ما يظهر طه محمد دكتور بهاء ما يظهروا لهم فوق في السلايد فوق. عرفت كيف؟ طيب
اوكي شكرا.
اوكي طيب دكتور سهير خلاص we start.
Yes, I'm ready.
اوكي دكتور بهاء you can start.
اوكي طيب بسم الله الرحمن الرحيم. الصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Welcome everyone for the continuation of this great initiative from International Society of Association of Pediatricians. We call it the academic part, which is internationally, with all our appreciation to our colleague from SAP Saudi for this initiative. Today the Qatar chapters is going to start it with one of our I can say eminent consultants. We have it in Hamad Medical Corporations. Dr.Sohair Elsiddig is a general pediatric consultant, which is holding a certified Arab board specialized in pediatrics, as well as a membership of Royal College of Pediatric and Child Health. And she's pioneering the medical educations, who is holding a master's from Warwick University, as well as she's an elite site of the residency program of pediatric in Hamad Medical City. And she's one of the holding very hard initiative, what we call is the academic support committee, with a main major outcome of developing of many our struggling learner. Today, she is going to speak about one of her expert topics about the growth chart interpretation and growth chart introduction to our pediatricians, which is titled with from growth chart to the diagnosis and outpatient approach to flattering growth. She made a lot of researches on this and with many international conference presentations. I'm not going to say more, but she deserves more than what I have been said. This is a very, very short kind of speak about Dr. Sohair, and she's also one of the first responder to any kind of help to our Sudanese in different initiative and different other projects which have been done from Qatar part. I think the floor now for you, Dr. Sohair, to greet our colleague, Dr. Muhammad Zain Karrar with us, and Dr. Taha, who holding this initiative also from us, with us as a panelist from Saudi part. Thank you very much.
Thank you, Dr. Baha. Assalamu alaikum, everyone, and good evening. It's a pleasure to be with you. And thank you for Dr. Baha, Dr. Taha, and for the Prof and for the organizing committee for this opportunity. And it's my pleasure to be with you all the time. And thank you for the kind introduction, Dr. Baha. So today I'm going to talk about one of my favorite topic when it comes to the clinical. A part of medical education, I'm general pediatrician. I'm interested in growth and in failure to thrive, or the growth faltering, the new definition. So we will do some scenarios and we will enjoy inshallah together. So just let me start by, I don't have conflict of interest to disclose. And by end of this presentation, I'm going to achieve a specific objective. But before talking about my objective for today's sessions, I would like to highlight that as a pediatrician, all of us, we care about children growth. However, most of the time, plotting the chart, the weight and height and the head circumference in the growth chart, sometimes it's only documentation. Sometimes during the busy life, we are not paying a lot of attention to the children growth, especially if they are not referred to this reason. So hopefully by end of this presentation will be all of us to refresh our mind about analyze the growth pattern using anthropometric measurements, growth charts, and the growth velocity to identify growth faltering and differentiate the physiological growth variant from pathological causes, and formulate a targeted diagnostic approach and develop and justify evidence-based outpatient management plan. Basically, I'm going to focus about integrating nutritional, pharmacological, and referral strategy, when to refer this child to subspecialty, when to refer to gastroenterologist and endocrinologist and other subspecialty. Now, why does growth matter? Growth is not only a body size. Growth, it will reflect the well-being of the child. It will reflect, it will be reflect our genetics background, our nutritional intake. It will reflect our endocrine, our GI system, and our psychosocial well-being. If a child deviated from his growth chart, this child might have only a celiac disease or a Crohn's disease, or sometimes this is a normal variant and I don't want to do any intervention. So growth is very important because healthy children, they have normal growth, and healthy children, they turn to be healthy adults. So growth is very important for us. Now, let me talk about my favorite point. Now, we have all of us the vital signs, and vital signs is very crucial, especially for ICU team, for example, for Dr. Baha and other teams. All the time, vital signs could be the earliest signs if this child is deteriorating. I'm considering the growth is the fifth vital signs. Instead of asking, is this child is small, I will ask myself, is this child is growing normally? Why? Because putting this question in my mind, it will give me a different way to look at the growth chart. Because sometimes you might have children at the 3rd percentile and they're doing completely healthy. And sometimes you might have a child who's declining from his weight or the body mass index, or he has a slow growth velocity and he's in the 10th percentile, and this child, he has an underlying pathology. So it's very important to have a growth as a vital signs, and growth assessment should all the time answer for a question. Is the growth appropriate for the age? Is this child growing well for his age? Is his growth appropriate for his genetic potential? Because I'm not comparing a child only with the growth chart. I'm comparing him with his genetic potential, with his mid-parental height. Is the child has normal growth velocity, normal weight gain velocity? Has the growth pattern is changed or no? All this is very important question. I have to put it in my mind when I'm looking at the growth chart. So before talking about the growth itself and clinical scenarios, we need to remind ourselves. Normal growth indicates children well-being, and the journey started not after birth, from intrauterine period. And this is one of the concepts of the 1000 day, which is started from the age of conception up to age of 2 years. So this is very important period for the growth of the children. So the growth is started during the intrauterine period, the fetal growth, and understanding that the fetal growth is affected by multiple factors, by uterine environment, by the mother nutrition, by the mother health situations. Also, it's affected by some intrinsic factor that affecting the fetus himself. For example, having chromosomal abnormalities and others. So growth during the intrauterine period, this is very important. And this is later on, you will find that all the time I'm asking in my cases, how is the child was born term or preterm? Is the child has normal weight, height, length, his circumference at birth or no? Because this is to reflect the intrauterine period. And after that, the child, he will be born. And in the first year of life, this is during the infancy, the child will have the maximum growth velocity during his whole life. In the first year of life, the child will gain up to 25 centimeter in his length. And although this is the maximum and rapid period of growth, still during this period, if there is any pathology or there is any deviation in the growth chart, it means that the main we have to focus is its nutrition, then nutrition, and then nutrition, because the nutrition is the main factor that controlling the growth during the infantile period, followed by other hormones like even the thyroid hormone. After that, after the second year of life, the growth will start to decrease steadily to 12 centimeter per year. In the third year, up to 8 centimeter per year, and then it will become very steady around 5 to 6 centimeter during the childhood. And after that, the growth rate will go for slowing, and then after that, will go for the second growth spurt in our life during the puberty. So during the childhood, still nutrition is controlling the growth of the child. However, here we see some effect of the hormones, growth hormone, thyroid hormone, not only nutrition and hormones, only the well-being of the child, the nutritional status, the psychosocial factor, all of this is going to affect the child growth. Having these factors in our mind, it will help us to guide our investigation and our approach for children in the later on. Also here at genetics, it will play a significant role in during this period. And when it comes to the pubertal, again, what will happen at that time, 6 hormones have a crucial role beside the growth hormone, beside the nutrition and the well-being of the child. Any deviation from this growth parameters, it will indicate underlying pathology. So looking at the growth chart, we have different growth chart, WHO growth chart, we have CDC growth chart, but looking at the single measurements, like a snapshot, it will tell you how is the child is today. But the most important things to look at serial measures of the growth, because it will tell you what is the situation of the child and where is the child is heading. Now, to look at the growth, let's do some refreshment. And I will just repeat the basics. Growth, if a child referred to me to the outpatient clinic, either by my colleagues or by parents, they came to me and they have a growth concerns. First of all, before doing an intervention, A, B, C, D, the first step, I have to confirm that this measurements is accurate, because having accurate measurements, having all the time, make sure the weight and the length or the height and it's taken in the appropriate way. It's anthropometric measurements, taking the anthropometric measurements. It's a very simple, cheap tool, can be done in a few minutes. However, it has very good impact in making the diagnosis. We have to make sure that the height was taken in the appropriate way, using the appropriate measurements, and for infant, it's the length, and for children is standing height above age of 2 to 3 years, and we have to make sure that all the measurements and the machines and the weighing scales is calibrated. After that, we need to make sure that it was plotted in accurate way, and we need to make sure that the previous measurements is reliable, because it will help to prevent missing any cases or over investigating a child. So this is very important, and you will look at this during our case discussion. And then we have to plot correctly. Meaning by plot correctly, it means that we have to use the accurate growth chart for the age and sex. I know that this is basic, but I have to emphasize in the basics. And we have to correct for prematurity. If you are used electronic system, we have to make sure that there is a correction for prematurity. And sometimes we have to use a specific growth chart for a specific syndrome, for example. Down syndrome, they have their own growth chart. It's completely unacceptable to manage a child, for example, with a specific syndrome, and you compare him with the normal population, because it will either you are going to miss a serious pathology in that child, or you are going to over investigate. So sometimes it might be very challenging to have the specific growth chart, but do your best to check the growth chart for a specific syndrome like Turner syndrome, Noonan syndrome, Down syndrome, and other syndromes. Now, after confirming the accurate measurements, plot accurately in the growth chart, we have to do some interpretation. I'm going to take you in the next few slides about the interpretation. The question is, which start first? Is it the weight? Is it the length or the height? Or this is the head circumference? Because it's going to change our approach for those children. And another important question, when the problem started, is it started few months back, or it started since birth, or it started since intrauterine period? This is very important point. And after doing evaluating the pattern, and I will go again for the pattern, we have to take history. History, it's a basic skills that we learned during the medical school. Still, it's a very important tool that helps us to diagnose children, not only with growth faltering, even with other diseases or pathology. History and history and history. No matter what's your level, you are a resident or you're a specialist, you are a registrar, you are a consultant or a senior consultant. If you're not taking a history like a medical student, a detailed, focused history, trust me, you're going to miss your patient. History is a key to diagnose children, and especially when it comes to the growth faltering. And in the history, I would like to emphasize the nutritional history, the social history, maternal history, family history, history present illness, history suggestive underlying disease, and birth history is very important. Birth history, because it will give you the prenatal, it will reflect the prenatal period. If there is any placental disease, if there is any maternal disease, if there is a torch infection, or sometimes in a specific community, if there is suspicion of fetal alcohol syndrome or chromosomal or genetic disorder. So history and birth history is very important, followed by physical exam. And after that, targeted investigation. And trust me, if you don't have a clue from the history and physical examination, it's very difficult to find a single test that's going to help you to know what's wrong with this patient. So nowadays, according to the recent evidence, target investigation not even required as a first step of management unless if you have a clue from the history and physical examination. So history physical exam is very crucial. After that, if there is indication for investigation, we're going to proceed with investigation, doing diagnosis and management. Now, just let me talk about the new definition, growth faltering is not a new definition since 2026. Actually, this terminology is there for the last few years. However, recently in 2026, the American Academy of Pediatrics and the NASPGHAN, they recommend to use the growth faltering instead of failure to thrive because it reflects a dynamic change in growth rather than assigning a diagnosis. As all of you know, growth faltering is a clinical sign that warrants evaluation and not a diagnosis itself. The preferred terminology, growth faltering, because it's descriptive terminology, it will describe the clinical finding, it will focus on an abnormal growth teratology and promote earlier recognition, and it will decrease the parents' anxiety when you tell them that your child is failing to thrive. All the time the parents, they will receive the blame, and it will facilitate objective communications. So this is when it comes to the terminology. As all of you know, that before when we diagnosing or defining failure to thrive, we said if the weight is less than -2 standard deviation, or the third percentile, if the length and height less than -2 standard deviation, before -2 z-score or standard deviation, or if there is the child crossing down more than 2 centiles. Now, in the new updated guideline, they added a few changes, and I do believe these changes, it will help us to promote early recognition and then early intervention. They added decline or weight gain or the weight velocity. Before, it was not there in the old definition of failure to thrive, because the earliest sign for a child to be falter in his growth or failing to thrive is decrease the weight gain per day. If you have the habits that whenever the child is coming to you, comparing his weight today comparing to the previous visit, if you notice that the weight gain per day or the weight velocity is decreasing, it will help you to early detect this child and to do the proper history and physical examination and explore what's happening before waiting for a few months till he will cross down his centiles. And another changes before it was crossing more than 2 percentile in the new definition, crossing 1 centile. And also they added reduce the growth velocity or the linear growth velocity. And also they focus about poor catch-up. For example, children with who born small for gestational age, if they did not catch up appropriately, also they put them as part of the criteria and definition. And this is very practical, and it will help you to look at the child from different perspectives and to detect them early and to do intervention early. Now, what is the relation between growth faltering and malnutrition? Is it the same definition? All children with malnutrition, they have growth faltering, but not all children with growth faltering are malnourished. And we're going to look at the cases. So sometimes you might have children who have appropriate weight or BMI or weight for length, sometimes appropriate growth velocity, but they are faltering growth, and sometimes you may have children, they have normal weight, normal BMI. However, they have a slow growth velocity. Those children also, their growth is faltering. So growth faltering is a big umbrella. Malnutrition, it could be one of the causes of growth faltering. However, we have other causes of growth faltering, and sometimes it could be this is just simple as normal variation or based on the genetic background. Am I going fast? Can you hear me?
Yeah, okay, Dr. Sohair, no problem, continues.
Okay. So again, you remember the first step when I mentioned that we need to if you have a child referred with growth faltering, we have to confirm that yes, this is the child is really, his growth is affected by ensuring accurate anthropometric measurements and plot in the appropriate chart. Now, let's think about weight first. So if the child and this is published in 2021 in the Italian Journal of Pediatric, this pathway that help us to direct our thinking. So if the problem started with the weight, so the weight falter first, as all of us we know, it could be either organic or non-organic, and most of the children with growth faltering, 80% they have non-organic and 20% they have an organic. And this can be divided in either they have decreased caloric intake, and usually like poor feeding techniques, incorrect formula preparation, or breastfeeding difficulties, feeding refusal, or other like gastroesophageal reflux or psychosocial problem, neglect, or affect problem with the parent-child interaction, poverty, and many factors. So, and usually for those children, we have to do detailed history and history. This is the key to diagnose those children and to do your management later on. And I want to emphasize on detailed nutritional history, feeding observation, and to have like 3-day food diary or 24-hour recalls, intake and output balance. And usually in this situation, investigation is not necessary unless if there is clinical indication. And the second category, children who has adequate intake, but they have poor absorptions, and history will help you to identify those children. Either they have symptoms suggestive of underlying malabsorption syndrome, they are atopic, they have eczema, they have some allergic reactions, they have constipation, altered bowel movement, or any symptoms suggestive of malabsorption syndrome. And if the history targeting or highlighting malabsorption syndrome, yes, at this stage, after doing proper history and physical examination, here investigation is required to confirm the suspected underlying pathology. And after that, you may consider refer to the subspecialty. And the third category, children who has normal caloric intake, good absorption system, but they have increased metabolic demand. So, and this is usually is our organic pathologies, children who has congenital heart disease, chronic lung disease, and other children. So again, history is going to help you, plus physical exam. And here also the investigation is guided. And the whole idea of all of this to have established the diagnosis and to target the management, and always consider red flag that suggests of organic disease like severe symptoms, severe growth faltering, abnormal physical exam, developmental delay, having dysmorphic feature, recurrent infections, persistent vomiting, diarrhea. So this is all a red flag for those children, or even sometimes neglect or severe dehydration. Now, if the weight is not the problem, then we have to approach the child in a different way, and we may need different subspecialty, or may need different approach to different investigation. So if the head circumference is affected first, especially in early infancy, then or if it's affected since birth, I will not think about malabsorption syndrome, right? Then I have to think about congenital infections, for example. Is it genetic syndromes? Is it brain malformation? Is it microcephaly syndrome? And I have here to think about detailed developmental assessment, detailed neurological assessment. And after that, based on my suspicion, I have to do recommended evaluations based, it's case-based. I'm not going to say to do testing for all of them, brain, MRI, neurological consultation. Let's take it case by case. But if the head circumference affected first, most likely we're thinking about either brain malformation, congenital anomaly, or genetic disorders. So the approach will be different. If the length or the height of the child is affected, however, with normal head circumference and normal weight, at this stage, we have to think in a different way. We have to think about, is it endocrinological? Is it skeletal dysplasia? Is it familial? And or do I need to refer this patient? Does this patient, he need reassurance? That this patient, he need growth hormone therapy? Does this patient, he need further evaluation for the whole thyroid and pituitary function? Or it's a part of a genetic syndrome? So this is very important to keep in our mind, which chart is affected first. Now, most of the children who refer to our clinic, and they will present with the weight started first. And we know that if the weight started first and the length or the height was not affected, and the head circumference is not affected, most likely this is an acute, and this is a wasted child. And if the problem persisted for a period of time, the weight will be affected. Later on, the height will be affected, and you will find that also the growth velocity is affected. And at this stage, you cannot say that I'm thinking about familiar, for example, short stature or constitutional delay, or I need to refer to the endocrinologist. We need to do nutritional rehabilitation first. And after that, if the patient did not improve, then we have to think outside the box. So the most important things, again, in this slide, if it's inadequate caloric or intake or nutritional absorption issue or increased metabolic, we have to, again, history, physical exam, and after that, investigation if it's indicated. And usually, what is the next step of management? The next step of management is nutritional counseling is the first prescription all the time, what we are going to do. Before prescribe specific nutrition, counseling is the key, because counseling is not only will solve the problem now, also it will help for maintaining this problem in the future, making sure that this problem is not going to happen with other children. So nutritional counseling is the first prescription. We have to counsel about age-appropriate diet, feeding techniques based on the child age. We have to counsel about the macro and micronutrient adequacy and responsive feeding, and I'm going to cover this in the next few slides. Counseling After that, if the child is malnourished, we have to do rehabilitation of the nutrition, and we have to address the underlying cause and underlying pathology. We have to optimize the caloric and nutrient optimization, not only high calorie, high protein, and sometimes we may need to have multidisciplinary support. And another very important message that I'm sending to myself and to my colleagues: close follow-up is very important, because identifying the problem, putting the plan of the management, initiate the management, the child, he may gain weight, he may improve. However, sometimes giving long follow-up or missing the follow-up, the child, he may deteriorate, or he will be static. So monitoring the growth is very important. Why? Because this is going to help you to assess the response, and it will help you to adjust the plan. And sometimes you may need to, if the child did not improve, you may need to reevaluate, and you may need to refer. So investigation sometimes it can be as a second line if the child did not improve. Sometimes referral to subspecialty, it's also if the child did not improve. And this is preventing us from requesting unnecessarily investigation. Sometimes we are limited in a place that we don't have enough resources, or the family, they cannot offer doing a huge list of investigation. And sometimes you cannot ask the family to travel from a place to place to see an expert, for example, gastroenterology or endocrinologist, and we did not finish our part. So this is very important. I do believe this is cost effective, and this is part of our role to support those children. Now, if there is no questions, I'm going to share with you a few cases. So the first patient, all those patients are real patients. They came and I had them in the clinic. So this is a very pleasant girl. She's Yara. She's a 10 years old girl. She came with her father concerning her height. Most of the patients who come to the clinic with their parents, the parents concerning about the height. I want him to be taller. He's the smallest child in the class. So concerning her height, she's an athlete's girl, some background. She played gymnastics. Actually, she's a champion. She's playing here in Qatar, and every now and then she will travel to a country to be part of the international gymnastic competition. She's and she has medals. So she presented to the clinic. So her past medical history: she was born term, with normal birth weight and length, and she was in exclusive breastfeeding, and after that weaning food started at age of 6 months, and she never has any symptoms suggestive of underlying disease. What's positive in her history: parents are divorced, she is living with her mother, and she's seeing her father during the weekend. And this is very important history, all the time to ask about this history. The mom is working, father is working, the child is doing very well at school. She will come from school, her mom is still at work. She will go and she will prepare her meals, her lunch. She will take her lunch, and basically lunch is chicken breast. She'll put it she will reheat it. It was grilled chicken breast, and after that she will take a banana, and after that at 4 she will go to do her gymnastic exercise. Every day she will do 4 hours per day, heavy exercise for 5 times per week. Coming from after doing her training, she will come, she will have like half sandwich of egg or turkey, and after that she will go for sleep. Usually her morning, she will take like a pancake, or she will take an egg sandwich. This is what she's eating during the day. It's very important for this patient to meet her and to do a head assessment. I'm going to talk about head assessment, and to ensure that she does not have any body image or she has any feature of anorexia nervosa, and her head assessment and was normal, and she does not have any body image. She doesn't have history suggestive of food aversion, and her physical exam is reassuring. And the father, when he came to the clinic, he brought her labs that he did in a private center, and she has normal hemoglobin, normal complete blood count, normal electrolyte, normal thyroid function test, and normal vitamin D. Now, as you can see, this is her weight. Look at her weight is far below the 3rd percentile. And not only the weight, at the right side of the screen, look at her body mass index is almost at -2 standard deviation. And also look at her height is almost -2.5. Now, you remember, we need to compare to the genetic backgrounds. And look at the parents' height. If you can see, the mid-parental height is exactly at the 50th percentile. So this child is almost around 2 standard deviation far from her mid-parental height. Now, having this child with me at that time, so I have, since she's far from her mid-parental height, it was obvious for me that she's not taking enough calorie, but still I want to make sure that I'm not missing any endocrinological problem. So I did, especially her growth velocity was low and around 4 centimeter per year, and the normal at her age to have between 5 to 6 centimeter. And her ternary stage is very important to assess for ternary stage. It was tenor 1, so she's pre-pubertal, and her bone age came to be, she has delayed bone age. So correcting her height to her bone age, so she is meeting her genetic background. So now for the small athlete girl, what is the most effective? So we have to do psychosocial therapy. We have to provide her with oral nutritional supplement. We have to do dietary assessment, counseling, and oral nutritional supplement. We have to give her appetite stimulant. We have to refer her to the pediatric endocrinologist or reassure the father since she has delayed bone age and she will catch up later. And it could be a hint or it could be a distractor. So what do you think? Do you have anything in the chat? So what do you think? What is the best answer for this patient?
We have answered C.
C.
Yes, they are answering C.
Excellent. So yes, 100%. The best answer is C. We have to do dietary assessment. We have to do counseling and to provide with oral nutritional supplement. Dietary assessment is very crucial. And dietary assessment and we have to see how much she's taking. 24-hour recalls. I took an assistant from our dietitians. She calculated the caloric intake that she is taking, and it's very important thing for children above the age of 3 years. As we know that as a pediatrician, everything calculated based on the weight and based on the age, right? So children, their caloric requirement and after age of 3 years, it has to be based on their level of activity. So I'm not giving a 10 years old child the specific amount of the calorie based on his age. Actually, if this child is a bedridden or with a cerebral palsy, he has decreased mobility, his caloric requirement is to be completely different than a normal child or a child with high physical activity like our patients. So this child, basically her physical activity is requiring more intake than what she's taking. Now, let me pause here and let me to highlight one important things that we don't want to miss in our patients. Health assessment is a psychosocial assessment for adolescent. It can be from 12 to 21 years, and actually you can even use it earlier, especially with the new generations. So basically, you're doing a screening for the home, education, eating, activities, drug, sexuality, suicide or depression, safety, or in other situations, sleeping, because you want to see if there is anything that affecting this child. How is the home environment? And this is very important, the psychosocial, any stresses, any conflict. Although the parents are divorced, but both parents, they are taking very good care of her, and like I cannot say that divorce did not affect the child, but both parents, they come into the follow up, and both of them, they are following the plan together. So, but the life cycle of both parents make the child, although she's at 20 years old, she's responsible about the amount that she needs to eat. Education, sometimes some children, they may suffer from problem at the school, bullying at the schools, and problem with teachers. So this is affecting them, and later on to affect their psychosocial well-being. Eating, and this is very important. What do you usually eat? And usually head assessment for the child himself. What does usually eat? Are they trying to lose weight, avoiding certain food? Any concern about the weight and about the body image? This is very important. And activities, are they involved in physical activity, or they have sedentary life, and what type of exercise and how much? Are they taking any medications, any drugs, any smoking, alcohol, especially for teens? And also we have to ask about their sexuality and about their mood, about suicide, about their depression, and also about sleep and if they are feeling safe. And we have all the time to ensure that the child, that all of this, it will be confidential unless it's going to harm the child himself or in homicide or suicide, for example. So this is regarding the head assessment. Although the child was referred for her height, but I do believe head assessment is very important, especially when the child also weight and BMI is affected. And again, and I have to remind you about the eating disorder. Eating disorder is very important, especially during the teens. And nowadays, with the social media and use exposure to unrealistic beauty ideas, filters, images, all this give the children different conceptions about their body image, about the body satisfaction, and they start to have specific idols and restrictive eating. So this is very important, how much you are exposed to the social media. So the risk factor of eating disorders, although it's more common in girls, but it's also increasing in boys nowadays, and usually they have rapid weight loss or growth faltering. Athletes at high risk of having eating disorders, and anxiety, depression, or heavy social media use. And it's just as a simple screening tool, the SCOFF screening tool, it just asks about, is 5 questions, and if you have more than 2 yes, it means that here this is positive screening, you need to refer or you need to intervene. So do you make yourself sick? Because you feel uncomfortably full? Do you worry about how or about your weight and about your eating, or you are losing control over how much you eat? Have you ever recently have weight loss, almost around 6.5 kg in the last 3 months? Do you believe that yourself is fat when others saying that you are too thin? And would you say that food determine your life? This is very important. A simple tool, it will help you to pick a serious disease, and this is very important. So please don't forget think about eating disorder, think about head assessment in your history, especially when you are evaluating a teen. So back to our patients, dietary assessment and counseling was done. So the child has she followed the plan as what we mentioned, high energy, high protein meals, and we put for her meals. We helped the mom to prepare for her the meals in advance. And also we started her an oral nutritional supplement. It's high caloric, 1.5 kilocalorie per 1 ml, to have it like twice a day, and with a close follow-up to the clinic. You remember this child at the beginning, she has low weight, low BMI, and even her growth velocity was affected. And in a follow-up within 6 months, she has significant improvement of her growth velocity. She increased 7 centimeters per year. And here, this is ruled out endocrinological problem. And this is her initial height and BMI, and this is almost with a follow-up, and still she's following with us in the clinic. Now, as I said, counseling and food is the first therapy. Food first approach. So we have to encourage family style meal to promote positive eating environment and to reduce stress. So we focus about high calorie, high protein diet, and to fortify the diet. Even if you don't have oral nutritional supplement, is not available, still this will not prevent us to put a prescription from the diet that is available at home, and all the time to teach the mother how to focus about the proteins, and we'll teach the mother how to make the food, although it's a small amount, it's high value, by adding like some nuts, sesams, peanuts, and creams. So this is very important. Now, why high protein diet is essential? It's important to focus not only in the calories, but also in the high quality protein. And high quality protein all the time, it's helped to promote the growth. Animal source protein is the best choice. It contains all the essential amino acid that needed to activate the mTOR pathway for children growth, especially the leucine, lysine, arginine, and tryptophan. And without adequate essential amino acid, the linear growth cannot occur, and brain development all the time it will be suboptimal. And we recommend, especially for animal source protein, comparing to the plant-based protein. However, let's say in some cultures the family are vegetarian. Again, we are going to recommend to focus about high protein diet from the vegetarian food, and we're trying to make sure that there is no other micronutrient deficiencies based on the diet that they are receiving. But high protein diet is showed not only promoting the growth, actually it showed also that mothers who's receiving high protein diet, it will help to determine the fetal growth, and also the during the pregnancy and during the amount of the breastfeeding. Oral nutritional supplement, many companies like Pediasure or others names, it's basically, what is the composition of oral nutrition supplement? It's 55% is carbohydrates, 15% protein, and 30% fat plus micronutrient. And the indication is mentioned by the NICE guideline, by the SPGAN guidelines, recently by the American Academy of Pediatrics. They ask for to provide oral nutritional supplement, especially if the child cannot meet his nutritional need through a diet alone. For our child, even if she was eating enough amount of the food, but still she need high amount of the nutrient and the calorie that meet her physical activity. However, it has to be prescribed and monitored by the health team. And the clinical practice, it showed that oral nutritional supplement, it will provide more than 50% of the micronutrient needs and balance macronutrients consumption. And usually the recommendation 1 to 2 times to receive oral nutritional supplement per day. And all the time we have to make it after meals, because children who receive oral nutritional supplement, they may have full stomach, and it may prevent them from taking others. So this is not our aim. So it will not replace the main meal. It will complete the main meal if the main meal is not enough to meet the child nutrient intake. And is it evidence-based? Yes, many studies done, and this is like some of them, about the impact of oral nutritional supplement in the growth outcome in the IGF-1 and underweight children. And it showed that oral nutritional supplement, it will help to improve the growth velocity, and it will help also to improve the weight gain per day, and it will improve the BMI. However, still there's a concern if used and monitored, it may lead to rapid weight gain, and it may lead to future obesity. So we have to use it with specific monitoring and follow-up. It's not just like, take this milk is a very good, and that's it. We have to follow the children closely. Okay, now I will go to another case. So he's the smallest child in the class. Now I have, by chance, she's another girl. This is a 9-year-old girl referred for poor growth. Her father is a nurse colleague, and he brought her because whenever he's going to get her from school, she's the shortest girl in the class. And he was not happy about her. She was born term. She did not require any NICU admission, with normal birth weight around 3.5 kg and normal birth length 50 centimeter. Her parents noted that she has been smaller since early childhood compared to her peers. And in general, she has poor appetite, and with early satiety, quickly she will eat like few spoons, and then she said, I'm full. Intermittently, she has a constipation. However, the father, he mentioned whenever he's encouraging fiber intake and water intake, her constipation will resolve and she never require any medication. She has no vomiting, no diarrhea, no abdominal distension, no symptoms suggestive of food allergy. She has no recurrent illness or recurrent infections, and her past medical history is completely unremarkable, normal developmental milestone. She has excellent family dynamics, socioeconomic status, and father, he's providing her multivitamins. A few months back, 6 months back, like she found she has iron deficiency anemia. Since then, he's giving her iron supplementation for the last 6 months, and he took it over the encounter. There is no family history of underlying pathology. Now, look at the left side of the screen. This is her weight. And if you notice that since age of 2 years, she was doing very well. By age of 6 years, there is something happen. So in the last few years, 3 years, that she crossed down her weight. However, the BMI per se is not a bad BMI. She's almost at the 10th percentile in the CDC chart. But in general, if you notice her BMI since age of 6 years is declining down. So, and the main concern from the parents that her height, she's not getting taller. She's wearing the same clothes for the last 2 to 3 years. This is only an observation by the parents. So looking at her current weight, she's minus 1.9, her height minus 1.8, and the BMI almost minus 1. Her growth velocity is very slow, and this is obviously mentioned by the father. She's 3.5 centimeter, and she's supposed to be 5 to 6 centimeter. And also the weight gain per day for her age, 2.7 gram per day, and expected to be 5 to 6 gram and above. And she's far from mid-parental height, if you notice that when it comes to her height, and also she's pre-pubertal. Examination showed pallor, normal systemic examination. And so what is your next step of management? Do you want for this child to do nutritional counseling, started her on oral nutritional supplement, follow up her after a period of time, or do you want to do an investigation for this patient? And if you will do you have any specific differential diagnosis in your mind? What you will order investigation? We cannot just order like a checklist, right? So yes, you want to do investigation. Someone is concerning about celiac disease. Okay, so CBC. So let's see. The investigation that we did for her in the clinic is showed that her hemoglobin is 10.9 with low MCV, low MCH, and her iron is low, and the iron saturation is low. And I'm telling you, this child, she was taking iron for the last 6 months, and when I calculated the doses that the father is giving her to her, almost she's taking 4 milligram per kg per day. So it's a good dose of iron. However, she did not get benefit, and still her hemoglobin is low comparing to her hemoglobin 6 months earlier. Yes, there is something wrong with this patient. So slow growth velocity and persistent iron deficiency anemia not responding. I do agree with all of you. I did for her the celiac screen, and her celiac screen came to be positive. Now, here this patient is telling us, is every patient that with a slow growth velocity, do I need to do celiac? Now, if you notice that the BMI was not that bad, almost around 10th or 50th percentile, minus 1.2. But celiac patient not necessarily to present with GI symptoms. Celiac patient not necessarily to present with low weight and low BMI. Sometimes they may present with short stature or poor growth velocity. And this is still taking us to the when I refer the child for gastroenterology, when I refer the child for endoscopy. So, and I couldn't refer this patient for gastroenterology before doing the basic tests, requesting a celiac screen for her. So based on the recent recommendation, if there is a clinical condition, clinical suspicion of a condition cannot diagnose without endoscopy, positive celiac screen serology, or the patient has persistent vomiting, dysphagia, or odynophagia, if there is significant feeding difficulty, or you suspect eosinophilic esophagitis, or other gastrointestinal disease requiring histological confirmation, this is one of the indications that you need to refer to the pediatric gastroenterologist. But make sure at least you evaluated the child, you did the initial management, and you started some supplement for this patient. If there is no improvement, or if there is high suspicion like our patient, do the test and refer to the gastroenterology. Now, in the new updated guideline, they mention when to refer to the endoscopy. It was highly recommended with the biopsy. So this is our second patient. Okay, I'm going to, if you know questions, I will go for the third patient. A picky eating. It's all the time we think about picky eaters all the time. Is it like, what do we mean by that? So also this is a real patient. This is a 5 years old boy known to have autism. He's known to have autism. This boy initial presentation actually was not growth faltering, honestly, but I took this patient retrospectively, and he presented with recurrent bruisability, bone pain, joint pain, and swelling for a period of 2 months. When I saw this patient, I saw this patient in inpatient hospital. But this patient, for the period of 2 months, he was seen by multiple pediatricians, and he has multiple investigations, including his hemoglobin, platelet count, coagulation profile, platelet function assay, peripheral smear, because recurrent bruising, bone pain, joint pain in a child, you cannot pass it smoothly. They thought about malignancy, they thought about rheumatological diseases, and this boy, he had a lot of investigation and nothing was diagnosed. He has multiple ultrasound for his joint and it comes to be negative. And he has an X-ray, and the initial X-ray was reported as normal. However, later when the patient he presented to the emergency, they did for him an X-ray, and the X-ray showed, by the way, a part of my filler, he has completely normal physical examination. So as you can see here, he has a severe osteopenia, and the white arrow, he has Franken line, and this is suggestive of scurvy, which is vitamin C deficiency. Now, looking at this patient, since he's an autistic, he has poor appetite. He has random meals, random snacks. His diet mainly depends on carbohydrate, starch, and dairy products. Not only that, actually, he was only taking dairy products from specific brands. For example, if he wants like flavor milk, for example, and from one brand and was not there in the market, he will refuse to drink other brands. This is part of his sensory component. He's taking cereals, soft drinks, cupcakes. However, he has very poor protein intake. He's not taking chickens, meat, egg, cheese, and he's not taking fruits and vegetables at all. And he has fair intake. Look at his weight. His BMI is not that bad. It's almost around -1 standard deviation at 50th percentile. And the weight gain is appropriate for his age. And even the height is appropriate for his age. But this is another case of growth faltering. Okay, this is a typical definition of hidden hunger or malnutrition due to micronutrient deficiency and hidden hunger. So now, what is the next step of management after giving this child vitamin C? Because of his restrictive behavior and sensory component, he refused to take vitamin C orally, so he was admitted to receive it in the hospital, IV vitamin C. And after discharge, what you are going to do for this patient? You are going to discharge with vitamin C only, with a dietitian review a responsive feeding plan. And what do you mean by that? Or you will add multivitamins and you will do follow-up within 3 months, or you will investigate for bleeding disorders. I told you already bleeding disorders seem to be negative. Okay, can anyone explain what they mean by responsive feeding plan? in the chat, and we will cover this in the next slide. Yes, the right answer is dietitian review and responsive feeding plan. So the aim of sharing this case to talk about rule of supplementation. Do we need to supplement vitamins for children who has growth faltering? Is vitamins going to impact our growth? Or no, do we need to supplement iron? Is there any recommendation? Is it an evidence base or what exactly? So multivitamins and growth. Multivitamins, it's evidence-based that it's improve height, weight in children, and it will benefit especially in the malnourished children, stunted children, or children with micronutrient deficiency. The multivitamins is all the time act as a cofactor for essential metabolic pathway. It will enhance the immune function and it will reduce the infection and improve the weight gain to promote a healthy growth. Multivitamins, it's very important. Children with limited dietary diversity, they should be supplemented with multivitamins. Children who has recurrent infections, anemias, or chronic malnutrition, or sometimes a region with high micronutrient deficiencies, you need to supplement the specific micronutrient supplement. Now, single versus multiple or multivitamins outperform a single nutrient approach. This is in one of the reviews articles that done in 2024, and it showed that the growth requires a synergistic combination of micronutrient. And at the end of the references, I'm going to put for you all the articles, and I can share it with Dr. Baha and with the team later on for your references. Now, is it safe? It's safe and well tolerated when given in the recommended doses and with a close follow-up, and over-supplementation should be avoided. When it comes to the iron is proven to have improved the weight gain, especially in preterm infant, and iron improve the linear growth, especially in children with iron deficiency anemia, and not only the linear growth, also iron, it will help to improve the developmental status and of children. And chronic iron deficiency, it will lead to decrease the cognitive function during the school age. So iron also, it's a very important supplementation. However, it has to be prescribed wisely, and the impact in the linear growth is showed mainly in preterm infant. Now, another area of questions, and many patients came, and many parents actually coming, that we would like to ask you about the L-arginine. And usually they are telling us like that was Zarafa or the giraffe medicine, because like most of the company, they put like a long giraffe in the L-arginine. And they said, do you think that is going to help our children to grow or no? Now, L-arginine supplementation, you need to keep in your mind L-arginine is over-the-counter medication. So L-arginine is one of the essential amino acid. So I don't have an answer, yes or no. I'm not with or against recommending the L-arginine. However, I'm going to discuss with you what evidence mentioned. So L-arginine is an essential amino acid. It has potential benefit for children with failure to thrive or growth faltering. It supports the protein synthesis, and therefore it helps the catch-up growth. It will produce the nitric oxide, therefore it will improve the blood flow and the nutrient delivery to the GI system. And it's mentioned that it stimulates the growth hormone and the IGF-1, therefore it will aid the growth. It will enhance the immune response, which is often compromised in malnourished children, and it may improve the intestinal repair and the nutrient absorption. So this is the potential benefit of L-arginine in children with growth faltering or failure to thrive. So there is no strong recommendation to give L-arginine to support catch-up growth. Like only like one of the studies, multivitamins with L-arginine supplementation can increase the linear growth velocity in children with idiopathic short stature without affecting the bone maturation. However, still we don't have strong evidence that recommend use as L-arginine alone to improve the growth velocity of children. Okay, so another case. Is the flow is okay? Do I have time?
Actually, we have almost completed 1 hour.
Yes.
We will give you like 5 minutes.
Okay, 5 minutes. So that can I have it 15 minutes? I have 2 interested cases because I need to cover the endocrinological when to refer to endocrine. But 15 minutes it will be enough, inshallah.
Okay.
Tamam. So some children are frustrated to eat. Now, Ahmed is a 4-year-old boy who referred for low BMI and picky eater. Okay, he has normal development, psychosocial. He has a stable family dynamics and socioeconomic status. And what's important, Ahmed has highly selective, eats bread, butter, green cucumber, and green apple. He avoids chicken, meat, eggs, and other proteins. Physical exam, it was completely normal. He's a thin boy with no dysmorphic features, with no signs of chronic illnesses. So this is Ahmed. Look at his weight. He's crossing down his weight centile. And look at his height velocity. More or less is maintained. And the BMI is down. So this is regarding Ahmed. So actually, I did not animate this. So Ahmed, basically, here we're thinking about ARFID or avoidant restrictive food intake disorder. This is one of the disease that coming to us in the clinic. If we did not think about it, we will miss it. And the intervention for avoidant restrictive food intake is completely different than other children. First of all, to mention this diagnosis, those children, they don't have body image. Because of that, they are not anorexia or bulimia. However, they have a specific pattern that it will say that they are ARFID, not as a picky eaters. So ARFID, it's mentioned in the DSM-5 since 2004, since 2013, and it's persistent eating and feeding disturbance with a failure to meet nutritional needs. And usually there is no concern about the body image. It's the diagnosis consists with avoidance or restriction of the food intake with more than one of the following. They have significant weight loss and faltering growth. They have significant nutritional deficiency. They have marked interference with psychosocial functioning. So they will not eat in the community, in the restaurant. They cannot eat in front of others. Eating time is very stressful for the parents, or even they cannot eat in the school or lunch with their lunchbox. They are dependent, most of them, they are dependent on feeding, like for example, enteral feeding or oral nutritional supplement. Okay, ARFID, not necessarily to have explained by other condition like OCD or autism. However, it's maybe associated with them. And usually in our patient, Ahmed, I forgot to mention, he used to struggle from gastroesophageal reflux disease. And at age of 18 months, he has choked one time with the grapes, and since that time he's became very restrictive. So usually they have, like, previous experience of choking, or they're afraid from choking, and usually they will restrict to specific type of the food, a specific smell, or a specific color even. So our patient, he was eating everything green. Apart of that, he will not eat. So, and to differentiate them from picky eaters, they have decreased variety of accepted food, but they will tolerate new food gradually, and they might have tantrum. However, they have shorter duration and they will improve rapidly. Now, it's very important if you have a child with ARFID, because here you need to refer. You need the dietitian with you or nutritionist, or to provide oral nutritional supplement. However, you need to do a psychosocial assessment, and you need to refer to the occupational therapist, because without multidisciplinary team, you cannot help those children. So multidisciplinary team and nutritional and pharmacological medication, especially if there is micronutrient deficiencies. The question is, what about cyproheptadine? So we know that cyproheptadine is not a new medicine, it's an old medicine, it's a first generation antihistamine, and it's an appetite stimulant. Have you ever give a prescription of cyproheptadine? Are you with or against providing cyproheptadine with patient with failure to thrive or growth faltering or underweight? So let me talk for 1 minute about cyproheptadine. So we know that the serotonin, it will work in the brain and from the hypothalamus, and it will signal the satiety, fullness, and it will therefore our appetite, it will be suppressed. However, the cyproheptadine, it's anti-serotonin, therefore it will reduce the satiety and increase the hunger and the food intake. And it was recommended by the multiple systematic review and multiple studies that is not recommended. It showed that it's increased the daily weight gain, it improved the body mass index, and it will improve the growth velocity. And it's safe with good tolerability, and if given with close follow-up. However, still there is no strong evidence that it will lead to future obesity or no. This information is not clear, but yes, cyproheptadine is proven to be given in children with faltering growth, and it will help their weight gain. However, whenever you stop the cyproheptadine, the child will go back to the same eating habits as before. You may use it as a temporary to bridge his weight gain and with the follow-up. Responsive feeding is very important for all children, either with the autism, with like our patient, the first patient, the athletes. All children, they deserve to have responsive feeding, which is a mutual fostering of feeding practice between caregiver and the child. It's a build the trust and the security. It will create positive eating environment. We have to eat together as a family. Nowadays, unfortunately, the father will eat by himself, the child with himself, watching his iPad or his reading his book. Mom will eat alone. There is no more family time. We have to have a positive environment, eye-to-eye contact, positive interaction, no screen during the meal times, no force, no fight. We have, as a parents and as a pediatrician, to educate parents to watch for cues, hunger, satiety, when the child is hungry, when the child he want apple, when the child he want juice, he want cookies, he عايز بسكويت. This is the time that he's hungry. However, he does not know how to explain himself. Therefore, he will go and take non-healthy food or junk food, what I'm calling appetite killer. Some parents, they said, give me appetite stimulant. Review the 24-hour recall, you find that the child from morning till evening, he's taking a huge amount of sugary drinks, appetite killer, chips, juices, cookies, crackers. Stop these, and then you will see that the child will start to gain his appetite again. Offer appropriate food, repeat exposure, follow your child, and let the child lead. Let you offer, and the child will decide. Responsive feeding is a foundation of lifelong healthy eating habits, bounding and enjoyable mealtime. Now, when I will refer to endocrinologists, this is very important because some cases is it us or do I need to refer to endocrine? So Rayan, 11-month-old girl, she was born 3 kg, and when she presented, her weight is 6.5 minus 2.9, and her length almost 70 centimeter minus 2.3, and the weight for length is not that bad, minus 0.9, as you can see in the growth chart. She has a slow growth velocity, 19 centimeter, almost she's supposed to be around 25 centimeter. Her weight gain is 6 grams per day, and bone age is 8 months, although it's not indicated in this patient. So this is typically a case of growth faltering. The question, do you refer this patient to endocrinologist? Yes or no? Do you refer this patient to endocrinologist? Okay, the question is no. Why? Because she's 11-month-old and she has poor weight gain compared to her age. So there is indication to refer children with growth faltering to endocrinologists. Yes, there is an indication. However, what it could be the indication if the child usually indication more than age of 2 years. Remember the first slide that I said in the first 2 years of life, nutrition is the main reason of poor growth. Weight and height both are affected. Children must receive nutritional support for 6 to 12 months. If there is no improvement at that time, you can refer to the endocrinologist. Most of the time, you will find them that they have normal BMI or weight for length. So this is another 4 years old girl who born 3 kg and her weight is almost -3 standard deviation with acceptable BMI -1 and the height is affected -2.3. Her growth velocity is slow for her age, 4 centimeter per year, and the bone age is 2 years. Do you refer this patient to endocrinologist? And again, here I'm going to say no, I'm not going to refer this patient to endocrinologist, although she's short. Yes, I said more than 2 years, BMI is almost normal, but if you notice that the weight gain is 3 grams per day. So this patient, after, I'm assuming I took a detailed history for all those patients and nutritional history, and there was no an underlying pathology. So what I'm going to do, child must receive nutritional support 6 to 12 months. When I saying that, yes, I need to refer to endocrine, the question, what is the endocrinologist will do different? Is the endocrinologist going to give medication? Is it a hypothyroidism? But usually children with hypothyroidism, they have signs and symptoms, or the child, he deserves a growth hormone. Do I need to do the workup? So before saying I will refer, is the endocrinologist going to change the management of this patient or not? Rahaf, an 8 years old girl who her weight was 3 kg, and Rahaf, she is short. If you notice that her parents are short, 145 centimeter, the mid-parental height -2.7, and her height is -2.68 with low weight, and she has normal growth velocity, normal weight gain per day, and this is obviously a case of familial short stature. Usually familial short stature, we're not referring them to endocrinologists. I'm not an endocrinologist, but I know that like many evidence showed that giving growth hormone for familial short stature, usually at the end they found after a few years of giving the growth hormone, when they achieve the final adult height, they increase around 3 to 4 up to 5 centimeters. The question, is it worth it or no? But I will not go in this debate. So familial short stature, usually we are not referring them to endocrine, we do counseling. However, yes, there is an indication to refer a child, familial short stature, to endocrinology if his height more than -2.5 standard deviation and this has slow growth velocity. If you find that is familiar, but the height is still, he will be -2.5 or -3, yes, refer. And if they have a slow growth velocity, refer. A trial of growth hormone they may receive, and after that they will evaluate. And some of them, they might have also growth hormone deficiency. So regarding Rahab, yes, we need to refer her because her height is -2.6. Yes, the mid-parental -2.7, but what if one of the parents, he was missed during early childhood? So if any child, his height, familial short stature less than -2.5 or slow growth velocity, refer to the pediatric endocrinologist. Now, Abdullah, a 9.5 years old boy, he was born almost average. Father concerning about his height. He's -2.5. His weight is -2.2, and his mid-parental height -1.6, as you can see in the growth chart. Now, Abdullah, he has normal growth velocity, and they did for him a bone age, and as you can see that the bone age is delayed, and this is obviously raising the concern of constitutional delay of growth and puberty. So usually the question is, do I need to refer constitutional delay in growth and puberty for endocrinologists? The right answer is no. Usually we are counseling the parents, and we are not only counseling and discharge counseling, and we are following them in the clinic every 6 months or to monitor their growth velocity. When I will be concerned about constitutional growth delay in growth and puberty, and I need to refer them to endocrinologists when they have a slow growth velocity, and if they don't have signs of puberty by age of 13 years for girls or age of 14 years for boy at that time. So our aim to detect those and to continue monitoring them and to refer in the appropriate time. So regarding Abdullah, so what if you notice that his growth velocity was within the normal, his weight gained 4 grams per day, and therefore we're not going to refer him to endocrinologists, and we will follow them. So usually constitutional delay of growth and puberty, they are the late bloomers, and they have normal history, normal physical exam, they have delayed bone age. When it comes to short stature, all the time, bone age is going to aid your diagnosis beside the growth velocity and comparing to the mid-parental height. And all the time, if you ask about the parents' history, you will find also the father or one of the family, he was also late bloomer. So bone age is very useful tool and is a very simple tool. If you have the bone age less than the chronological age, and at that time look for the child growth velocity. If he has normal growth velocity, delayed bone age, this is constitutional delay of growth and puberty. If you have abnormal growth velocity, I mean slow with delayed bone age, it could be this is because of the endocrine problem or nutrition or chronic illness. Remember our first patient that the athletes, she has pure nutritional problem and her bone age was delayed. So at that time, after giving proper nutritional, her growth velocity guided us and it's improved. And at that time, I did not refer her to the endocrine. However, if you have an X-ray finding for a bone age for any child with short stature, a normal bone age, normal to chronological, equal to chronological age with normal growth velocity, it could be this is familial short stature. However, if the child has abnormal growth velocity, at that time it could be underlying genetic. You need to investigate further, and you need to refer to the endocrinologist because some genetics or some syndrome they are indicating to receive growth hormone therapy. So any abnormal growth velocity, refer to endocrinology. So I'm not going to talk about these patients. However, small for gestational age, children who has a small for gestational age all the time, if they fail to catch up by age of 3 to 4 years and they have poor catch up, please refer them to the pediatric endocrinologist because is indicated to receive growth hormone therapy. So indication to refer children with for trial of growth hormone if they are more than 2 years with no clinical signs of a disease, and you make sure that they receive optimal nutritional support for 6 months. Okay. So now indication to refer for pediatric endocrinology for children with failure to thrive if born small for gestational age or preterm and they did not catch up their height after age of 2 years. You can optimize with nutrition and follow them. And however, if they did not catch up later, you refer them. Any children with constitutional delay of growth and puberty with a slow growth velocity, familial short stature with a slow growth velocity, or if the expected final height less than -2.5, Russell-Silver syndrome, achondroplasia, Noonan syndrome, and Turner syndrome, and others. So the last, I have 3 more slides for syndromic failure to thrive. I can proceed or I can stop here.
Dr. Baha, you have any comments? We can give her 5 minutes. Is it okay with you?
That's good, actually, Dr. Ahmed. No problems.
Okay. So why I have to talk about syndromes? Because remember earlier I was telling you growth start intrauterine. and having the normal birth weight, having the data of term or preterm birth weight, length, and head circumference, it will tell you if the problem started intrauterine. Is it intrinsic or extrinsic? Intrinsic, we mean, could be in the fetus himself. It could be genetics. So we know that genetics, syndromes, it will lead to growth faltering. Endocrinological problems will lead to growth faltering, and nutrition, it will lead to growth faltering. This is a common syndrome that if you face those syndromes, they well known to have failure to thrive or poor growth. Some of them being a failing to thrive or poor growth, if they continue, this is part of their syndrome. You don't need to do a lot of investigation. You need to utilize their own growth chart, and some syndrome you need to be familiar with because you need to refer to the endocrinologist, because some syndromes, they showed good response on growth hormone therapy with nutritional support, like Russell-Silver syndrome, Noonan syndrome, Prader-Willi syndrome, 3M syndromes, Turner syndrome, Cordelia-de-Lange syndrome, Char syndrome, Williams syndrome, Down syndromes, and sickle syndrome. Down syndrome, I'm not mentioning that he need to be referred to endocrine. This is a common syndrome that they have growth faltering. You need to utilize their own growth chart because they have a specific growth pattern during early life and later on, not necessarily only to be failure to thrive. Growth issues often, they begin with IUGR. Usually they have postnatal deceleration of the growth, and most of them, they have feeding difficulty. So the mechanism of their growth failure, either by endocrine abnormalities, they have problem in the growth hormone IGF-1 disruption, like Russell-Silver Noonan syndrome and others, or they have hypothyroidism like Turner, Down syndrome, and Williams, or hypogonadism like Prader-Willi and Turner. Or they may have adrenal dysfunction like Smith-Lewis optis, Prader-Willi syndrome. And some of them, because of the nutritional contribution, they have feeding difficulty, or they have malabsorption syndrome like cystic fibrosis. So knowing the underlying pathology, it will help you for the treatment outcome and the management strategy. Early diagnosis, critical for improvement of the growth and development. And syndromes, they need multidisciplinary care. They need pediatrician, nutrition, endocrinologist, genetics, development, and swallowing assessment, and occupational therapists and other team members. Syndrome-specific therapy has to be tailored to the hormonal profile, and nutritional support is the foundation of the therapy. So growth hormone response, strong response to the growth hormone noticed in Prader-Willi, Turner, Russell-Silver, 3M syndrome, and Noonan syndrome. However, the nutritional support is the foundation therapy for all those children, syndrome. And this is my last slide. This is a real patient who was admitted frequently to the hospital with recurrent infections to the pediatric floor and to the pediatric intensive care more than 7 times in the 2 years of life. So I followed this patient at age of 14 months, and at that time she was failing to thrive, and her weight was 7.3 minus 2, and her height was 71 centimeter minus 2, and she has a slow growth velocity. So she does not have a part of recurrent respiratory infection that requiring multiple hospital admission, and she was born 35-week IUGR with very low birth weight and birth length, and her circumference, she was SGA. All of this led us to think about underlying genetic syndrome. And yes, this patient proving to have one of the rare syndrome that he has affection of the Papa gene, which is one of the genes that affect the growth of those children. And it's well known, documented, that those syndrome, they have growth hormone resistance or IGF-1 resistance. And usually they have poor growth and poor nutrition and short stature that evident by age of 6 years of life. However, I would like to show you that this patient, we admitted her to the hospital to receive nasogastric tube feeding, high caloric formula for a period of 6 weeks. And after that, the child, she started to take all the amount of the nutrient by age of 18 months through the mouth. and all the milk that through the mouth. Therefore, we remove the NGT feeding. And following this patient in a period of 4 years, if you notice that although this is part of her syndrome, but optimizing her nutritional, it led to the red is the length and the blue line is the weight. And look at her weight is significantly at age of 18 months, improved significantly with the nutritional support, and it will reflect positively in her length. And she from -2 almost at around to be -0.8. And after that, what happened? Was during the COVID period. She lost the follow-up. And at that time, the mom was not focusing in her. So mom was not focusing on her nutrition. Therefore, her weight gain decelerate again. And if you notice when the weight gain decelerate, her length also decelerate and growth velocity decelerate. When mom came back to the clinic and we start to focus about her nutrition again, her nutrition reflected positively in her weight. Therefore, her height improved again. And this is telling us the home message. Nutrition and management is crucial for patients with growth disorder syndrome. Regular follow-up and adherence to the nutritional guidelines are essential for effective management. And thank you so much. This is all my references. And I'm more than happy to answer your questions. And thank you so much. I hope it was light presentation. I hope.
Thank you very much, Sohair, for your very comprehensive kind of talk. And I guess it's very important kind of topics now, especially nowadays. All of us, we know our country is passing with very challenging periods, actually. It's not surprising. In my last visit to Sudan last week, I came. A 2 case of celiac crisis was in one of ICU in the capitals. And such a patients with this kind of growth delay, they have their specific changes in physiology, endocrine, as you see the varieties of cases coming. So it's one of the important topics that we need to be very carefully when we diagnose, when we approach, when we investigate, actually. And I guess you cover all of this. I couldn't find any question in the question bar or in the all some appreciation and comment of about your presentations. But I will let the floor for Muhammad or Taha if they would like to close the session or have any comment about the topic. Thank you very much, and hopefully with our next presentation will be in schedule soon, and we'll give the priorities for as scheduled, inshallah. Thank you.
Inshallah. Thank you so much, Dr. Baha.
شكرا يا دكتور بهادين. Thank you very much, Dr. Sohair, for this very nice, informative session. I just have 2 comments. You did it very nicely, and you went through everything in a very good way. And lots of comments, lots of thank you, appreciations for the talk from the floor. عندنا feedback form. We have just people. I would appreciate if people could fill the feedback form. Muhammad will put the link in a minute. It will be nice, and it will give us good information about what people want, who would like to subscribe, where they are from. If we just give them half a minute to fill the feedback form, Muhammad, please put the feedback form. I want to comment on the celiac presentation for latest guidelines. Well, I think in Sudan we should stick to this. If the TTG is more than 100, full stop. Previously we used to do the HLA genes, but now I don't think we need to do this. If it's more than 100, more than 10 times normal, you can treat a celiac without scoping, because scoping is, it's even in the third way, like in Ireland and UK, more than 100 is enough to diagnose celiac according to the SPGAN guidelines. Like طبعا هنا احنا بنعمل الجينز، لكن it's I don't think it's available in Sudan. Even if it's available, it will be very expensive. This is one thing. If you suspect celiac and you are in Sudan, you can do the TTG. If you don't have the TTG, if you are in remote area or very expensive, you cannot do it. You can just try the child off gluten for a couple of weeks, 3 weeks, 4 weeks, and see the response. If he responds very well, you can challenge him again. And if he deteriorates, that means it's a celiac disease. this thing is important. في comments من ال my question is
Tahana, I have actually a lot of thank yous. We have one Zoom user. He is raising his hand. We'll ask him to open the mic. The Zoom user. Actually, we have also Dr. Rashid Ahmed also raising hands. So we will give chance for two.
Just regarding your comment regarding the celiac, yes, I do agree with you 100%. The recent guidelines from the SBGAN, if highly suspected of celiac disease and the T2G is positive, you can diagnose without a scope. And when it comes to here to our practice, and even in that guidelines, that still in our practice, because we have access to the gastroenterologist and they're the one who's following cases with celiac disease, they will, based on the figure itself, some of them they will do scope and some of them they will not do scope, and they will diagnose and they will continue following the child. So yes, if there is high suspicion, you can eliminate, and later on you can follow the patient. The question is, if you don't have the test and you don't have a gastroenterologist, and at the same time you eliminating the gluten, it's at that time the family will be stuck, and sometimes you don't have a lot of access to gluten-free diet. So you need to do very proper counseling if you decide not to do scope and you don't have the facility what the child will eat. Because later on, if this child did not improve his growth velocity because he's not taking enough, or because it's not, for example, a case of celiac. So again, yes, we have to tailor it based on our situation in Sudan, and this is the updated guideline. Yes, thank you so much. However, if you're not quite sure, better to refer.
Thank you very much. I was just saying, you know, في Sudan, يعني if you just ask them to eat, you know, sorghum, اللي هو الذرة والدخن, they will be okay. But I'm sure, you know, if we have the facilities, and by the way, gastroenterologists, they love scoping. Yeah, lots of people are not happy with it. You know, I know this because I'm one of them. So they love to scope, and lots of them not happy with these guidelines. But you are right. I think if you have the facilities, use it. If you have the resources, if you don't have it, then you need to tailor your practice. Thank you very much, Dr. Sohair. زوم يوزر، ما عارف مين الزوم يوزر، تفضل.
يس، السلام عليكم ورحمة الله. دكتور ابتهال الأمين الطيب, Associate Professor Jazan University. Very thank you for this very rich, interesting presentation. Actually, I have one concern regarding the slide concluding the relationship between malnutrition and faltering growth. I believe that malnutrition and faltering growth overlap, but neither implies the other, as malnutrition is abnormal nutrition, maybe due to stunting, micronutrient, or even obesity, while faltering is abnormal growth trajectory. Another justification is that faltering growth is based on serial growth measurement over time. We cannot mention this child has faltering growth from one visit. While in malnutrition, we can diagnose from one visit. So that faltering growth rely on figures. It is quantitative, while malnutrition is qualitative. Do you agree with me?
Yes, I do agree with you. And the whole idea of making this presentation, we had multiple presentations about malnutrition and the severity of malnutrition and all forms of malnutrition. However, like we need to open the eye for other form of faltering growth, not per se malnutrition. For example, when to suspected, yes, the majority of malnutrition could be part of them. However, we have like syndromic, they may not necessarily to have nutritional issues, or a small familiar short stature or constitutional delay, when to follow up them. All of this part of the faltering growth. So if you notice here, the concept, I did not talk about the severity, when to admit to the hospital and when to start. Now I make it like broad expansion of faltering growth as a pediatrician or general pediatrician, we're the first line who will pick those children, and then we will decide, is it a nutrition issue, we need to address it, or we need to refer to specific subspecialty. I agree with you 100%. But again, malnutrition, I could put it as part of the faltering growth. However, it's not only nutrition, there is endocrinological and genetic and others. So I try to make it as a big picture.
Okay,
But
thank
I
you.
agree with you 100%, yeah.
Okay, thank you.
Okay, next we have Dictora Sid Ahmed, Rashid Sid Ahmed.
Assalamu alaikum.
Wa alaikum salam.
Thank you, Sohair. Thank you so much for this outstanding lecture. وزي ما قالت واحدة من الزميلات هي فعلا حتكون مرجع إن شاء الله في nutrition. I have one comment and one suggestion. Suggestion is to have celiac disease per se as a next lecture if possible. I think this is so important. Celiac crisis. Now we are seeing Sudan in Nelson textbook as one of the countries of celiac disease. I think we need celiac disease per se as a lecture. This is my suggestion. My comment, I want to highlight in a small piece you put in acute weight loss in as a cause, the child neglection. I just want to highlight on this point because nowadays we are seeing this child neglection, multifactorial issues. And I want to highlight, as you said, Sohair, it is an important, but we need more elaboration in our countries and outside the countries as a child neglection with all elements of it. And thank you again. Thank you so much.
Thank you. Yes, I do agree with you 100%. Child neglect is very important, and not only in the history, sometimes you'll find the signs of child neglect in physical examination. And we had like multiple patients admitted to the hospital at that time and suspected to have like non-accidental injury and child abuse or psychosocial deprivation. And those children will not improve unless if you address the psychosocial aspect. And it's well known to have psychosocial the psychosocial, it may lead later on to not only faltering growth, also to dwarfism. This is, yes, 100%, and we need to keep this in our mind in the history, and we have to be very good observer about the interactions between the family and between the child during the clinic. And of course, the impact of the war, there is multiple factor nowadays is affecting the children. So we have to keep this in our mind.
Yeah, actually.
Sorry, تفضل يا هادي.
That's okay. Yes, and just a comment actually for Dr. Rasha. I think May will promise you actually we have two very brilliant gastroenterologists, new fellows have been graduated recently. I will put it Taha and Muhammad now in our list that's about celiac and celiac crisis, sure for being in this academic lecture, inshallah, in near future. Only my comment also just to address because I'm really appreciate all our colleagues what are doing now in Sudan. But the consideration about how to treat this patient, how to feed this patient, it should be taken very critical point view. I'm not from my background as critical physician, but about how to feed this patient. I think the huge numbers now will be there. A lot of misplaced kids, a lot of missed follow-up with whatever background cause or about problems of this changing in their now is gross velocity or gross weight gaining. The importance is awareness how to deal, how to gain the weight or how to put on a plan. As Dr. Sohair in the last few slides is concentrating about the plan with the dietitian referral. I think we have a dietitian referral, but I'm telling you, I'm going to raise the risk sometimes if even we're not probably plan how to put a plan of proper feed for these patients. As we know, will end it by a crisis, which is well known for us as a major cause of death in a patient with malnutrition if not fed well. I think this is one of the important serial if we take it on the refeeding syndrome, this celiac crisis, and this, because this is now one of the main front desk problem our colleagues in Sudan they are seeing. And most of the patients, almost like 90% of admission for any other reasons, they do have the malnourished as one of the problem list, and they need to deal with it. This is just my comment about what Dr. Rashid highlighted now.
شكرا بهادين. في question about familial short stature and growth hormone benefits. Can you explain من زياد يا دكتورة سهير؟
Okay, so again, like I need to highlight that I'm not an endocrinologist, but again, like familial short stature. So because I'm doing an MDT clinic with the pediatric endocrinologist and I'm attending with them the updated conferences. So regarding familial short stature, if the child, let's say, is -2 standard deviation at the 3rd percentile, and the family at the 3rd percentile, and he has a normal growth velocity. So most of the family, they come and we need a growth hormone. This is not an indicator because we need to weigh the benefit and the risk. What is the potential benefit of this growth hormone? Because eventually of long-standing studies showed that it will affect the final adult height around 4 to 5 centimeters. The question, growth hormone, first of all, if it's available, this is not an easy medication. It has its common side effect. It may lead to impaired sugar, and it will lead to thyroid dysfunction. It has many side effects. I'm not saying this to make people afraid from the growth hormone. And still in the recent conferences, there is an association between increased the risk of malignancy or no. This is also area of debate. So the question is, keep in your mind also the cost of the growth hormone. Growth hormone is not a cheap medicine. And the moment you start the patient on a growth hormone, then you will continue till having, for example, the puberty sometimes for 5 years, 10 years, or depend. So the way, the benefit and the risk is, a patient is his final adult height, a female, it will be around 150 or 149 centimeter. Okay, and this is familial short stature, almost -2 standard deviation. And she continue to have normal growth velocity. Is the benefit and risk is going to, do I need to start her or no? However, if the child, we expected that the final adult height to be less than -2.5 centimeter. So, or if the child has slow growth velocity, yes, refer to the pediatric endocrinologist. And trial of growth hormone, it may be given, plus minus if they would do growth hormone simulation test. And if the child showed there is significant improvement in his improved growth velocity, and the final adult height showed improvement, they will continue. However, some children, they have normal growth hormone simulation test. It started in growth hormone, and after 6 months or 1 year of the follow-up, the growth velocity, it continued to be the same. So they did not benefit much from the growth hormone at that time. Based on my experience with my colleagues, they will stop it. So again, as a pediatrician, I have to know for a familial short stature when I will refer to the subspecialty, and I will let the decision to be by expert in the subspecialty. But I have to be aware about the indication. I have to give realistic expectation for the family, because I don't want to give the family that, yes, there is a medicine, it will help your child to grow. And then I will refer the family. The family, they may travel sometimes from state to state to meet the expert, and sometimes they will be disappointed if they found the medicine is very expensive. However, is really indicated or not. So we have to think about when I have to refer. But again, I will keep this for the expert if there is any endocrinologist. But this is based on my experience. هذا والعلم عند الله. So one question about the arginine and appetite stimulant can be used at any age in the chat. So the cyproheptadine, it was mentioned to be started at the age of 2 years, and almost the dose around 0.25 milligram per kg per day, divided to 2 to 3 doses, but not to exceed a specific dose. L-arginine, it's a supplement. So I don't have a right answer, but I do believe it can be started after age of 2 years, but I don't have a confirmed evidence-based answer for this. But cyproheptadine, it's after age of 2 years, not before age of 2 years. L-arginine, still we're not recommending to use it. We don't have a strong evidence. And if the child has a balanced diet with a balanced protein, he will have all the essential amino acid, not only the L-arginine.
Brilliant, Victoria. Thank you very much. And as I said, there's lots of comments and thanks and appreciations. It was really pleasure to have you today, yourself and Dr. Baha for our Qatar team. I think you raised the bar. This was an excellent presentation. We benefit from it a lot. And we look forward to see you again in your next cycle. شكرا جزيلا.
Thank
محمد.
you so much.
Thank you very much for your comments. Thank you, Dr. Sohair, Dr. Baha, for joining us today. I hope everyone who has any topic who would like to present from Sudan, communicate with Dr. Yasser Jebra and tell him that he is interested to present, and we will make the floor ready for him to present from Sudan, and we will be happy to help you in presenting with the technology and all these things, and to listen to the also cases from Sudan. See you next week, as Dr. Taha said, and we're very sorry for going more than 2 hours today, but as you see, it was interesting presentation and with a lot of questions. Thank you, and see you next Saturday with a group from United Kingdom, and have a good night.
Thank you so much. جزاكم الله خير.
Thank you, everyone. Thank you.
شكرا يا بهاء، شكرا جزيلا، يديكم العافيه. الله
Absolutely.
يسلمك. الله يسلمك. بارك الله فيك. الله